Hey, it's Dr. Centeno, and thanks so much for joining me this morning. Today, we've got an interesting topic to talk about why different doctors get different conclusions or draw different conclusions from the same CCI imaging. I often talk about things that come up during the week, and this came up during the week where I had a patient's mother that I was communicating with, and I think she had possibly seen a surgeon who had drawn different conclusions from the same imaging. So I felt this was timely because this is a question I get quite a bit, right? A patient goes in and they get a certain image done, and one doctor concludes X from the image, and then they see a second doctor who doesn't think they have X, and then a third doctor who thinks they have Y, etc. So I thought this was a good time to start diving into some of this and why that tends to happen. And again, why that happens with craniocervical instability. So as usual, I'll do a small bit of lecturing up front, and then we'll get to the second part, which is Q&A. If you've got questions, put those in the comments where you are. And the sooner you get those in, the sooner I'll answer them. And almost always, I end up with more questions than I can answer in an hour. So just a tip here is try to get those questions in as early as possible if you want to get them answered. So again, just to repeat, this is a talk about why different doctors draw different conclusions from the same type of imaging for CCI. And we'll do a little bit of that, and then I'll do Q&A. You can ask questions about this topic or really anything at all. And if you want to ask a question, put that question in the comments where you are. And the sooner you get it there, the better, because almost always I end up unable to answer all the questions that I get. And if you don't want that to happen, then get your question in now or very early in the presentation. So again, we'll start here now with why do different doctors draw different CCI conclusions from the same image. Also, you might be asking why I'm wearing a German World Cup shirt. I don't really have any affinity for World Cup soccer, although I think it's interesting. This is just a shirt I bought on the trip, the last trip I made, and I thought it was kind of cool. Obviously, I see a lot of German CCI patients, so hats off to Germany here. And I'm representing your team today. Not that I wouldn't love the American team, but it just happened to be that this was the shirt that was there that I thought looked the coolest. So it has nothing to do with my affinity for German soccer, but I thought it was a nice shirt. Okay, so let's get going here. Let me pull up the lecture so we can get started. Okay, so this weekend I was at the IOF Toby conference. Happened to be here in Denver, which was fantastic for me because I just got a chance to drive. I didn't have to fly. Everyone else had to fly there. And IOF Toby is really one of the more serious regenerative medicine conferences focused on spine and orthopedic injuries. It's an organization I helped found many years ago that's kind of now taken on a life of its own. So I'm the old man in the crowd. And it was a lot of fun. We had this Autologous Gods thing that you see there, which is why I'm in a toga and why everyone else is in a toga. That actually had to do with a crazy sales rep on LinkedIn who was pushing allogeneic birth tissues that are based on the research we've published in one of the top journals on earth in orthopedics. We showed that those products don't contain any living stem cells that survive to do anything. but he was pushing that. And then we were talking about autologous therapies having much more data. And we all got branded as, quote, autologous gods. So rather than push back against it, we went with it and turned it into a session at IOF Toby talking about autologous therapies. So that's why I'm wearing a toga here. So patients often get frustrated by different doctors drawing different conclusions from their imaging. And in CCI, it's really bad because you can see one doctor who says you have Chiari, another doctor who says you don't, one doctor that says you have CCI, another doctor says, I don't think this person has CCI, or maybe one doctor thinks you need a lower neck fusion, whereas another doctor doesn't, and it goes on and on and on. So why does this happen? And I'm going to focus specifically in CCI just to give you some sense of the fact that this isn't really black and white. So for CCI, most physicians use metrics that are very much less stringent than the ones that we use. Now, why is that, right? Why doesn't everyone use the same imaging metrics? You would think that that would be the case for CCI or for anything. And patients in particular, and some providers often think that these imaging metrics for CCI are well established and well studied. And so they believe that when they see a physician or a surgeon, if that physician or surgeon says, I think you have CCI based on X or Y, they believe that that's a sort of universal guideline for craniocervical instability, when that really isn't. So again, it's a myth that there are some hard and fast rules for who has this type of CCI versus not. Now, realize that if we're talking about the type of CCI that requires emergency surgery out of the emergency room, that's different. And in general, with regard to those patients, there is more or less standard diagnostic criteria. But when it comes to the type of elective surgery CCI that I see and that exist much more commonly, there aren't really hard and fast rules. And I'm going to show you some of the variation here. So there's some concepts here, right? The first is that there is symptomatic versus asymptomatic CCI. The second is that measurement cutoffs exist. So let's talk about symptomatic versus asymptomatic CCI. When it comes to craniocervical instability, obviously you can find CCI in patients that don't have symptoms. And my goal is to try to make sure that when I'm seeing a patient, the images that I'm looking at that seem to show CCI are causing them symptoms, because unless they're causing symptoms, there's no reason for me to do what I do, and there's no reason for that person to get fused. And what do we want in a measurement cutoff for CCI? Well, we really want measurement cutoffs that allow us to identify when someone is likely to have disabling symptoms. And we don't want measurements that artificially catch people in a wide net who might have no symptoms, right? So I always use the rule of, if I take 100 people off the street right now, and if a CCI measurement could find that 30 of them or 20 of them have CCI, when none of them have CCI symptoms or disabling symptoms, that's a really bad measurement cutoff. I should look for a measurement cutoff that really only has a false positive, which is what that would be, very rarely. And that's how this should work. Now, again, as I've said, surgeons often use metrics that are found in textbooks, and those are usually very different than the ones that we use. And that's because hunting down the source studies that separate symptomatic versus asymptomatic CCI patients, using those cutoffs, I found very, very difficult, meaning that most of the cutoffs I've seen used don't have good studies showing that they can identify symptomatic patients versus non-symptomatic patients, or on the other hand, that these measurements aren't common among people with no symptoms. So let's explore some common CCI measurement cutoffs to learn about the diversity of opinions that are out there. So let's look at C1, C2 overhang, Grabb-Oaks, CXA, and translational BAI. So C1, C2 overhang, that's AP, open mouth, lateral bending view. Patients going this way. And we're trying to see if C1 translates laterally on C2. DMX is preferred. You can do it on X-ray as well. And what's the difference between a surgical overhang and the measurements we use? Well, we've seen some physicians and surgeons use the old numbers here as anything more than 2 millimeters, when in fact the Freeman-Katz study changed that to 3 to 4 millimeters with an asymmetric DENS. And if you're at 3 millimeters, there's a 2/3 chance of symptomatic CCI. If you're at 4 millimeters, there's a 95% chance of symptomatic CCI. Another one is Grabb-Oaks, right? Grabb-Oaks, as the line I've drawn there, is if you draw a line from the Bayesian down to basically the back corner of the DENS, and then you draw a second line that goes to the back of the DENS to that line. That's called the Grabb-Oaks measurement. And again, most of these are done on upright MRI these days. Here, several physicians and surgeons use the value of greater than 7 or 9 millimeters. Here is the definition of symptomatic CCI requiring fusion. We use the Nicholson data, which is on upright MRI, which kind of moved that to at least sort of 10 millimeters in flexion for that to be abnormal. The concern there would be if we use 7 millimeters, we're going to catch a lot of patients that don't really have CCI. If we use 9 millimeters, the Nicholson study showed that approximately 1.5 out of 10 patients will have a normal finding. So that's why we move our abnormal up. Now, there are certainly patients that have 9 millimeters where they've got a lot of compression from the DENS to the brainstem, where you could make an argument that you should relax that rule. So all of this has to be looked at in context. CXA, clivaxial angle, the angle formed by the clivus, and the back of the DENS. Again, most of this these days gets measured on upright MRI. And several physicians and surgeons use the value of less than 135 or less than 130 as the definition of symptomatic CCI. We use the Nicholson definition of abnormal as less than 125 in flexion on an upright MRI. Again, we could use 130, we could use 135. We're just going to capture a lot of patients that have normal findings. Again, this Nicholson stuff just has to do with trying to prevent getting the values or the same values of someone I pick off the street who has no symptoms. Translational BAI is another one. Again, this normally these days gets picked up on upright MRI. That's the distance from the Bayesian to this artificial line drawn at the back of the DENS. And here we're looking at translational values from flexion to extension. And that's going to be the difference between the two. Now, several physicians and surgeons use the value of greater than 1 millimeter. Henderson published a long time ago on the idea that we should probably move that to 4 millimeters. And that was really prophetic because that's before the Nicholson study came out on upright MRI that showed that, again, it's rare that people who don't have CCI report more than 4 millimeters or more. So what happens if the patient is offered fusion based on the metrics and we don't agree with those metrics? We do make an exception in that case if the patient's only option is a fusion. So in that particular situation, we will tell the patient, listen, we don't think you have CCI, but a surgeon does. And if this is your only option to get surgical fusion, then as long as you realize that you may not have symptomatic CCI, we will do a PICL because you don't have a lot of other options. So in summary, our CCI metrics are often stricter than those used by most physicians and surgeons. We tend to focus on metrics that are obviously abnormal based on what's published, or metrics that link to symptomatic CCI. But again, when patients don't meet our criteria and their only option is a fusion, they can opt for the EPICL as long as they realize that we generally disagree with the diagnosis. So again, just to review, there are lots of metrics out there for CCI. Our goal is to try to be a little bit more strict. We're a little bit more strict because we are trying very hard to separate patients who clearly have craniocervical instability, likely causing symptoms, from patients who might have incidental findings that look like craniocervical instability, but at the end of the day, what we're seeing on the imaging isn't causing their symptoms. Because when I treat those kinds of patients, they're not going to change or get better. So just to end that up there, we'll move to questions now. And I'm going to just take a 1-minute break here before I start questions, so don't go anywhere. I just need to adjust a few settings on my side. Okay, sorry about the little break there. So let's get started with some questions here. Let's adjust that a little bit. Alex, feels like muscles turn off if I go out of alignment for more than a few days. Becomes hard to hold head up and stay in good posture. Find myself falling forward more when sitting. Is this normal and why? Yeah, I think, Alex, as I had, I believe, said on Reddit, the concept here is that when the body perceives pain or abnormal information coming from one of the upper neck joints, what tends to happen is the muscles shut down. And that's probably why we see muscle atrophy in many CCI patients. Now, the ultimate treatment for that is, in your case, obviously, maybe upper cervical chiropractic, trying to stay in alignment, obviously working on the ligaments to try to stay in alignment as well, and then working on the overall muscle strength so that you can have both ligaments and muscles there. Casey, and I remember you telling us of certain tolerances in various CCI types, i.e. C1, C2 overhang of X millimeters, the threshold for being symptomatic or not. It'd be great to see a table with each CCI. Yeah, that exists. I think I've posted it before on the Reddit sub. There's even a little app on the Reddit sub that you can put measurements into, and it'll tell you exactly if they're normal or abnormal. Nikki, based on your experience, do you think it's advisable to recommend a PICL without considering the symptoms, but only based on imaging results? We always look at symptoms, and we always look at functional disability. So if you just have abnormal imaging and you have no symptoms, then you're not a PICL candidate. You're not a surgical candidate. You not only have to have symptoms, but you need to have symptoms that are preventing you from doing what it is you normally do. So for example, we do have patients that live in a functional box where they can control their symptoms, but they don't do A, B, C, D, E, and F to control those symptoms. So they're not really living a normal life. So realize that we would discourage using PICL or any kind of fusion procedure to treat just the imaging if someone didn't have significant symptoms. Was a soccer coach. CCI comes from headers, maybe. It's possible. It's certainly possible that you could get CCI from a header. Probably less likely to be active heading of the ball, but more likely to be getting hit in the head with the ball. And the reason is that if you're doing a header, you're actively turning on those protective stabilizing muscles because your head's going to hit something. That being very different than not expecting a blow to the head, where you can't really protectively brace. Alex, how do you know when to stop procedures? For example, if someone feels good after 2 PICLs but still has 4 millimeters of overhang and was 8 originally, should they get one more in an attempt to resolve that overhang? Yeah, so it's a combination of disabling symptoms, how someone is responding to those PICLs, and we could also look at imaging metrics as well. So for example, let's say we had someone who was 60% better after 2, and we know they generally get about 30% with each one, and they're still living in a substantial functional box, and they respond well to procedures. Procedures don't cause them 3 or 4 or 5 months of flare-up, etc. Then it would kind of be a no-brainer, to recommend a third PICL if they still had 4 millimeters of overhang. Now, compare that to someone who is 90% better and is much more functional and getting back to all the things they enjoy. Then we're probably going to hold a little bit and see where that goes before recommending that third PICL. D Spicer, seeing you guys soon. Looking forward to getting fixed and getting some relief from these symptoms. Love the videos. Thank you. Look forward to seeing you as well. I know some DMXs insist on getting rotational dynamic views, which I remember you don't use. What do you think is its value? Yeah, at this point, I don't think there's much value in getting dynamic rotational views. Frankly, I don't think there's much value in most of the DMX views. It's one of the reasons why when we started doing DMX in office, I don't waste radiation on dynamics rotational views because we don't really know how to grade those and determine what's unstable and not. I don't waste money on oblique views where patients are bending their neck because, again, we really don't know what's abnormal or not. I don't usually waste radiation on nodding views because we, again, don't know what's abnormal and not. So when we do DMX, we focus on the views that are very specific to finding what's normal or abnormal for that patient. And that means we eliminate about half of the DMX. That's why I call our DMX a low radiation DMX, because we're eliminating about half of the radiation exposure or more. Nikki, do you have any tips for managing CCI and AAI on a daily basis, for example, physical therapy or micronutrients? Well, you should always try physical therapy. We have online exercises to try. You can also get with a experienced physical therapist. If you're looking for a specific physical therapist in your area, then that would be IPA, like the beer, IPA physical therapy. If, on the other hand, you're good with an online therapist, then we use Todd Ball. But you should always try those management steps. Other advice for managing CCI would be finding an AO, NUCA, Blair, orthospinology chiropractor, because those are the chiropractors that are very specifically focused on the upper cervical spine. How could one doctor see, basically, this is a fancy word that means some changes in the vessels leading into the base of the skull and think it's an important finding. Others do not see it or think it doesn't matter. Yeah, I think you have to be careful here. So for example, I've seen what I call overread reports, both in the upright MRI world, and I've seen overread reports in the DMX world. In the DMX world, they tend to be what I call the damage reports, where it says big yellow highlight, damage, 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 damage. Most of the time, they're not highlighting damage as much as they are just degenerative instability. Same thing here. I've seen upright MRIs where all sorts of things get called that are beyond what you can really determine by looking at an upright MRI. And this would probably be one of those examples. Upright MRIs are really not focused on and good at looking at blood vessels. There are MRIs that are really focused on blood vessels. That would be an MR venogram or an MR angiogram. So again, you have to sometimes take these overreads with a grain of salt. Now, as a patient, how would you know if there's an overread? That's something I'm happy to talk to you about. And I have no problem discussing that with my patients as I see them for telemedicine candidacy, of just saying, listen, I think this is way overread here. You may want to get another opinion on A, B, or C, or you may want to get another imaging study to see what's going on. Vera, why are PANIS not called on MRI? Because we have to be careful here, right? If you're talking to most radiologists, a PANIS is a very, very, very large extension at the back of the dens that's fluid filled. And we're talking about, it's so obvious you could see it from across the room. Now, that occurs in rheumatoid arthritis patients who have craniocervical instability. Then there's what I would call a PANIS, and what some of the CCI surgeons would call a PANIS, which is much, much smaller than that, but it does narrow the distance between the back of the dens and the brainstem. So you have to be careful there, but most radiologists aren't going to call that as a PANIS. They're probably just going to ignore it. So again, this is where we're seeing differences between what radiologists have been taught to read, i.e. a PANIS and rheumatoid arthritis that you can see from across the room, versus looking at swelling in the back of the dens that might decrease the room between the dens and the brainstem. Jess, if you have AI and CCI, is it possible to do a PRP all over the neck to stabilize in hopes that the other area is strengthened enough to hold the other ligament in place long enough for it to heal? No, that usually doesn't work, Jess. So really what you're talking about is what I call the shotgun PRP approach, or blind prolotherapy type PRP approach, where they kind of just stick the needle in all over the place, but don't have the skill level to inject the high upper cervical ligaments like ALAR that you mentioned here. That usually doesn't work. Now, who knows? It may provide some benefit, but usually when it provides benefit, there are more symptoms coming from something like C2 moving forward on C3, which that could help, than coming from the alar ligament. But no, I generally wouldn't waste your money. This is something I see a lot with patients, where patients waste a lot of money getting repetitive Prolo or repetitive PRP. There's one clinic out there that does this 6, 8, 10, 12 times, and the patient has burnt through $20,000 or $30,000 getting all of these treatments, and they've got no dry powder left to do anything else. It didn't work, and now they've kind of painted themselves into a financial corner because they can't get the type of treatment that's more likely to help. Alex, to add to that, if someone is able to hold adjustments for longer after 2, still some overhang and minimal symptoms. Yeah, Alex, I think we kind of got there with the last answer, and that is, at the end of the day, the goal is to look at it all in context so that we can make a good decision, because regrettably, it doesn't come down to just imaging metrics. It's always trying to look at the bigger picture for that person. Vero, 5 months PSL number 1. I'm still unable to do level 1 laser clock exercises. I get dizziness, tachycardia, and jaw tightness. What could this indicate? Probably means, Vero, that we're going to need to continue. I would say that probably 2/3 of our more significantly impacted CCI patients can't do the level 1 clock exercises after their first procedure. Now, again, everyone's different. We have people that blow through them before we treat them. We have people that blow through them after the first or second procedure, etc. But it probably just means you're more significantly impacted and need more care. Again, can't comment on your case specifically, but that's just in general. Can a single PRP injection fix CCI? A lot would depend on the type of CCI. Realize that, again, the focus that we have is specifically what type of CCI are we talking about. So in general, even if you had something that was fixable by a posterior PRP injection, which would be something like say a CCI type 3A, where C2 is going forward on 3 with neck flexion, usually it's going to take more than one PRP injection to fix that. And you're going to want to make sure that the doctor has the ability to put the PRP not only in the ligaments, but is using X-ray guidance with contrast confirmation, so they can also inject those 2-3 facet joints as well. But even in that situation, one PRP injection is unlikely to get most patients where they want to go. If you have more internal ligament CCI, like a type 2B, then it's very unlikely that that type of approach is going to help. Vera, how many months after PICL could we expect upper back and neck muscle tightness to decrease? Vera, I think you had said that you're 5 months out, so that's about when we'd expect to see that. If that's not happening at 5 months out, then usually the next thing to do is, if you've made iterative improvement, but just that or other things haven't improved, then we usually just proceed to the second treatment. JS, does CCI or does certain CCI get worse over time? What helps with CCI symptoms without surgery? CCI can get worse over time in most patients. So again, best I can do is to say, in most people we follow, because let's say they decide not to get a treatment and they pop up 2 years later, most of them are worse rather than better over that time. But we do see some people that get better over time. So there's no way to say that advice or that trajectory applies to everyone. What helps CCI symptoms without surgery? That could be specific neck injections that are focused on the CCI type. So as I said, a type 3A, 2 going forward, and 3 in flexion might just be simple posterior injections. Or advanced posterior injections, whereas a type 2B, side to side at C1, C2 due to alar ligament, is going to map to that PICL procedure. It's been advanced by Sherry Scott. Is it expected that CCI will get worse without treatment over time? I think I just talked about that one. Why light sensitivity doesn't go away, BVD was found. I probably need more context there, Kevin, to answer that particular question. I think I answered that one already, so we already got that third time here. Linda, do you see any differences in responses to PICL procedures by patients based on the causes of the CCI, due to physical trauma, injury, or hypermobility? Yeah, it's interesting. We have looked at physical trauma versus hypermobility, for example. We don't see any differences in outcome between those two groups. JS, when do you recommend C1-2 fusion with symptoms and without? Or, not quite sure the question there. Someone would have to have disabling symptoms and disability for me to want to recommend a C1-C2 fusion. If they don't have symptoms, then we're generally not recommending a C1-C2 fusion unless there's extenuating circumstances. So, for example, I think I talked about a few Facebook Lives ago, a patient who I had seen a couple months back who had very clearly transverse ligament laxity, a very large opening in the atlantodental interspace with neck flexion. He was offered surgery but had no symptoms. Even with regard to PICL, we had to have a long conversation of, I don't know if we should do a PICL if you have no symptoms. Now, there was always the concern in that kind of situation specifically that there could be some sort of potential increased risk for this person. Hence, we sent him back for more imaging to get a good read on what that transverse ligament looked like. Nikki, can you tell me if diagnosed convergence insufficiency can lead to my symptoms? Things that happened days, months ago seem unreal, and I have short-term memory issues. Sorry, video to eye movements issue. Yeah, so convergence or problems with coordinating the eyes can cause lots of different issues, including memory problems or derealization feeling. Now, then you have to get into what's causing the convergence insufficiency. But I think the first thing to do would be to see a vision therapy optometrist to try to rehab that conversion insufficiency, or try to improve your eye coordination, working as a team, if you will. And then if that didn't work, then you'd have to go to the next step and say what's causing that. So CCI can be a cause of that. Other things can be a cause of that as well. What about translational BDI? What is the threshold you consider? Yeah, so for translational BDI, that's going to be 1 millimeter. The Nicholson study did confirm, it's one of the few things the Nicholson study confirmed, the current surgical understanding. The current surgical understanding is 1 millimeter or more. Now, that's hard because getting a clean BDI measurement, 1 millimeter is within the measurement bounce or the statistical bounce from one doctor to a next, to a third, to a fourth, to a fifth. You're going to have an accuracy of measurement there of at least 1 to 2 millimeters, meaning if the 10 doctors perform the same BDI measurement, especially on an upright MRI, they're going to be a little different. Someone might come up with 6, someone might come up with 7, someone might come up with 5, etc. So using 1 millimeter as a hard and fast rule is probably not a great idea. Probably a better idea to use at least 2, because in that case, you know that you're not just measuring something a little differently than the last guy. But again, you can see how difficult this can be, right? If we're doing it on a CT scan, then we're going to see less variability. If we're doing that same measurement on a really good upright MRI, then we'll have more variability between doctors than on the CT scan. And regrettably, if it's a bad upright MRI that's very fuzzy, then we're going to have even more variability between doctors. So again, Dr. A might get normal, Dr. B might get abnormal. I'm not quite sure what the question here. Ligaments get strength by prolotherapy. Prolotherapy can work to strengthen ligaments. Can PT and chiro strengthen ligaments versus tendons? If you strengthen muscles, will it strengthen ligaments? Not so much, but realize that stability is half muscles and half ligaments. So really the overarching goal there is to get stronger so that it protects your ligaments. Now, if you get stronger and your symptoms go away and you don't have crazy ligament values, then I think it's probably fine to just watch that and see where that goes. Having said that, if you try to strengthen and things blow up, then you're probably in that category of needing some ligament strengthening usually through injection in our world, but might be a fusion candidate as well. Andrea, would it make sense to get a DMX for each procedure to see the progress? You can certainly do that, Andrea. We offer DMXs in the office. We have done that for patients. Some of our patients don't want to do it because of radiation exposure, but we're happy to do that. The problem is that there isn't a linear correlation based on what we've observed between a decrease in DMX values and symptoms, meaning we have patients that have no change in DMX values and whose symptoms are responding very nicely. We have patients that have large changes in DMX values and have no change in symptoms at all. Where I think DMX repeats can be helpful is if we're looking for a tiebreaker. If we're trying to say, are we doing anything here to this person because they don't seem to be getting better symptomatically? And can we document to ourselves that we're making some improvements in something here? JS, during PICL, can you tell if ligaments are not functioning properly? Sometimes, for example, we do put the patient in a position with force that can open a really weak ADI or a really weak transverse ligament. So we have seen that, but mostly what we're getting is feedback on the structure of the ligament. So we can tell, for example, if the ligament is very loose packed and looks injured versus if the ligament is very tight packed and looks mostly strong and intact. Casey and I agree with not treating asymptomatic patients, but surgeons often will say without fusion, you'll be paralyzed on MVA neck injury prevention. Yeah, Casey, we have to be careful with that one because not in this area, but I've looked it up in cervical stenosis. So that's a hard sell on surgeons where they'll see a stenotic patient, meaning the spinal canal is very small, and they tell patients, gee, if you get into a car accident, you could become a quadriplegic. The problem with that argument is if you look at the research very closely, which I've done, you're actually more likely in that situation to become a quadriplegic from the surgery than you are from a car accident. So be very careful there. These surgeries are not zero risk or close to zero risk. They are very invasive. So you'd want to make sure that you're talking about a patient who has clearly substantially abnormal metrics and has symptoms when they do something wrong. Let's say they're mostly asymptomatic, but they do X wrong, and they can have a symptomatic flare for 2 weeks. So you've got to document big motion and document that they're symptomatic when they do something that pushes them into that big motion. Outside of that, oftentimes the surgeries are higher risk than the risk you're trying to prevent. So it's a very complex calculus there you've got to look at, but important to try to protect the patient as best you can. I think I've answered this one already, so I'm not quite sure what the question is there. If someone has CCI measurements but no symptoms, will they eventually get symptoms as the structures get more and more damaged? Uh, it's certainly possible. We know that instability over time can eat up joints. So it's certainly possible that we're seeing patients early who have too much movement, and eventually that movement will cause symptoms. Can a dental infection lead to CCI? I would say not usually, no. Not one health journey when treating CCI along with SI joint and shoulder instability. What improvements do you look for that indicate the entire kinetic chain is stabilizing? Big one would be symptomatic and functional, right? So that's going to be that the CCI related symptoms, things like dizziness, balance, headaches are getting better, that the SI joint pain or pelvic pain or back pain is getting better, and that the shoulder pain is getting better. And all of those things are allowing more function. CRM Eology, hit the thumbs up. Yes, guys, hit the thumbs up. Give me a like, share, comment, subscribe here. Thank you for reminding me to do that. A lot of times I forget to do that because that's how people find this information. So if you want to pay it forward and make sure other CCI patients know about this and can join in, hit that like or thumbs up button because that helps other patients find this content. Does CCI get worse over time if you're only doing AO chiro to maintain symptoms, but the atlas continues to come out of place? Yeah, Jess, so I think I answered that before, but the concept here is that in general, yes, it does for most patients, but there are some patients that will go the other direction too. So most patients, yes, fewer patients, no. I postponed my PICL based on recommendations from my orthodontist and periodontist to wait until my bite is more stable. At the moment, none of my back molars are making contact due to complications of something. Sure. Again, when it comes to should you do a PICL first or should you do dental work or splinting or working on TMJ first, a lot of it really just depends what's bothering you more, right? If you can't eat much of anything and you're off solid foods and you just have a few CCI symptoms, then you would certainly want to go the dental route or the TMJ route first. If, on the other hand, you have mostly disabling CCI symptoms and not much going on with your jaw that's functionally disabling, then that would turn around and go the opposite direction. Didi, is occipital a common symptom? Occipital is a common problem. Headaches would be a common symptom caused by occipital, but that would be a common problem in our CCI patients. Jubilee, from a prior dental treatment, I've noticed a strong connection between my bite, stability, and neck stability. In your opinion, is it important to achieve a more stable bite before proceeding with PICL? Well, Jubilee, if you've noticed a connection between your bite and your CCI symptoms, then I would say yes. I'm not quite sure what a connection between my bite stability and neck stability means. I'm assuming you mean that when your bite is off, your neck gets worse, in which case I think pursuing trying to improve your bite is helpful up until that point where obviously nothing seems to change and you've got to start moving on to the neck. Hypermobility plus whiplash, symptomatic cervical instability without meeting the CCI criteria. What treatment options do you consider after conservative care fails? Yeah, so again, realize that there's craniocervical instability and there's craniocervical syndrome. So craniocervical syndrome just means that you have upper neck structures causing CCI-like symptoms, but there is no instability, in which case you focus on treating those high upper cervical structures. So generally, that's the next step if you don't meet the criteria for craniocervical instability but have upper cervical symptoms. Does a Regenexx provider do PRP differently than an ordinary chiro provider? I wouldn't be getting PRP at all at a chiro office. That's a really, really bad idea. Uh, Listen, 70% of what it is you're looking for when you have CCI is not playing the magic stem cell game, meaning that you're not out there trying to find some magic potion that is going to cure your CCI. So, umbilical cord stem cells. I've seen a CCI influencer recently who's trying to push all of this craziness. Or going to a chiro office who only has the expertise to put whatever it is they're injecting into muscles. 70% of what you're looking for is the expertise on how those things are placed, and 30% is what is injected. So obviously that's a mismatch, right? At a chiro office, you're not going to find that expertise. And you really need to do your homework on that, but that's not where you're going to find this kind of expertise to get that stuff exactly where it needs to go. What you're generally going to get is some some super expensive trigger point injections, and it's going to be a waste of money and super risky if they're going near your upper cervical spine. Andrea, if you can't afford to get PICL every 6 months, getting PICL every year, every other year, would you still see the same benefits? Yeah, Andrea, I think as I often say, we had that experiment happen during COVID, meaning we had patients that for whatever reasons weren't coming in for 1 or 2 years. They were putting their care on hold because of COVID. And we saw about half of those patients maintain their gains. So we were talking about 1 to 2 years in there. And half of those patients did not. They regressed because they needed that ongoing care to gain enough momentum to get them where they needed to go. Kevin, why SCM feels so irritated? Flexion extension showed no evidence of CCI, just this herniations, but prolotherapy or PRP help. SCM irritation is usually linked to C1, C2 instability. You really wouldn't see C1, C2 instability on flexion extension. That's going to take usually an open mouth lateral bending view on a DMX. So there may be undiagnosed type 2B. SCMs can also get fired up due to postural problems when your head and neck come very much forward. Disc bulges in the neck are not usually the cause of SCM tightness. Vero, after 1 PICL, I'm now able to turn my head left, but lateral bend causes suboccipital pain and headaches. What could this indicate? What is still damaged? Well, I don't know specifically what's still damaged from that description. I can say that it sounds good that you had some improvement in the ability to turn your head. Realize that when you're turning your head, that's stressing the alar ligament less, alar and accessory less, than when you're laterally bending, which stresses it more, which is why we use the lateral bending open mouth view during that DMX to look at and really stress the alar ligament. Is bubbly head sensation always CCI? No. That could be, I'm not quite sure what you mean by bubbly head sensation, but headaches and other types of things involving your head could be CCI, could be 20 other different things. Amber, Andrea, they have for me. I took 2 years between my first and second, still got great results. Good to know, Amber. That's, I think you're in that half of our patients that can put bigger time frames in there. So that's wonderful. James had CCI from a crushing neck injury in 1999, had a bunch of lower cervical fusions, and a C1, C2 injury that was never treated. I have a lot of symptoms. What treatment options would you recommend? Yeah, James, I don't do online consults. Obviously, that wouldn't be responsible. But we do offer telemedicine visits where I can look at all of that information and try to determine what you're a candidate for. So that would be the next step. You would also want to try to get movement-based imaging to see if there's any kind of CCI. And then we're happy to do a telemedicine. We even do a pre-screen before the telemedicine to make sure we have everything we need. Actually, my mom did some sort of acupuncture on me to help with some chronic ankle pain. She grabbed my head and pressed on my ear really hard. I'm now having a lot of pain. Yeah, so I think actually I answered this. It's certainly possible that something got injured, but normally these bumps in the road type small injuries don't affect the overall outcome from something like a PICL procedure. And then could CCI affect the thoracic spine? It can, or at the very least, we see a lot of CCI patients that have upper back and thoracic issues as well. And oftentimes we'll treat those as well. Could instability lower down the cervical and thoracic spine, amplify instability at the CCJ? Unlikely. Usually what we'll see there is that patients who have lower cervical and thoracic issues generally just have multiple areas that are causing symptoms, right? So sometimes the CCI or the upper cervical spine gets in on the axe, sometimes lower cervical spine, sometimes the thoracic spine, and then these three areas can play off of each other. Molly, during the PICL procedure, can you see if ligaments are calcified? If so, would you not inject? Yeah, Molly, it'd be pretty rare. I can maybe count on one hand after doing this quite a bit. The times we've seen, or I have seen, a calcified upper cervical ligament. What we do see are bone spurs getting sort of pulled off of the bone, or osteophytes from ligaments. But as far as mid-ligamentous calcification of an upper cervical ligament, that would be more rare and might be a reason to head a different direction, like fusion. Jess, are there any prescription medications given before or after PICL? What happens if the person has been floxed and worries about medication sensitivities? There are medications given during the procedure. There are medications given after the procedure for pain, etc. We don't use any fluoroquinolone antibiotics. Can CCI contribute to psychiatric issues like depression and anxiety? We certainly see a lot of chronic pain patients who are depressed, and that's fairly common, including in CCI patients. That makes sense. As far as anxiety is concerned, CCI can contribute to anxiety through irritation of the vagus nerve, but there's also other causes of anxiety as well. Have you seen, heard of sleep apnea mouth devices make CCI worse? Not really CCI worse, but we certainly have seen that things like CPAP and BiPAP machines, because they keep your head and neck in a certain position, can aggravate CCI symptoms. Okay, so we're coming up to the end here. See if there's any specific questions. Here's a good one. Jess, is there a specific area in the neck that controls the dizziness? Yes, the most common level for that is C2-3, and then a little bit less so at C1-2. But usually that high upper cervical spine controls the dizziness. Okay, guys, so I think we're all done for today. I want to thank everyone for hanging around and thank everyone for all the great questions. Again, as I always say, that's a great way for everyone to learn, is by asking questions and then getting answers, because a lot of us have the same questions. So thanks so much for your time on this Sunday morning. I will be back next week doing the same thing on another topic. Probably do just some general stuff on stem cells, because I've seen a lot of misinformation out there recently on that topic, but we'll see where the week goes, and I'll pick a topic at some some later date as the week goes on. So thanks so much for spending time this morning, and have a great week.